Hello, and welcome to the first PAME webinar of 2025. I'm Gardiner Lapham, a co-chair of PAME, and pleased to be moderating today's webinar titled Breaking the Silence, Epilepsy Stigma in Africa and its Impact on Outcomes and Pathways to Change. Every February, I get excited because it's an opportunity to learn about epilepsy beyond our borders and think more broadly about ways to narrow the staggering global epilepsy treatment gap. As a reminder about our webinars, please share your questions in the question box to help me keep track of questions. Feel free to use the chat features to connect with other attendees. And for questions, please put those in the Q&A section. You can apparently upvote questions that you have the most interest in. And a recording of today's discussion will be made available within 24 hours, and we will send it out in an email once it's online. So today's webinar is in recognition of International Epilepsy Day, which was February 10th. Every February, I get excited because it's an opportunity, as I mentioned, to learn about epilepsy beyond our borders. And today, we'll be shining a light on epilepsy stigma and how it can impact quality of life and epilepsy outcomes. I want to thank UCB for sponsoring today's webinar and for being a true champion of SUDEP awareness specifically and global epilepsy awareness more broadly. So now I'll quickly run through today's program and make just brief introductions. First, we'll hear from Professor Ley Sander, who is Professor of Neurology and Clinical Epilepsy and the head of the Department of Clinical and Experimental Epilepsy at UCLA Queen's Square Institute of Neurology in the UK. While his bio is far too long to read today, please know that Professor Sander is a world-renowned expert on epilepsy and has consistently been ranked as one of the top epilepsy specialists. We're extremely honored to have him here today. After his presentation, we will screen The Curse of Stigma, an award-winning short documentary film that sheds light on the pain, isolation, and harm that epilepsy stigma can cause. I had the honor of co-producing this film with Hannah Witten from the Witten Newman Foundation, and so I'm glad we can share it here today. And then following the film, we'll hear from Patrick Ngechu, who is the Chief Executive Officer of the Kenya Association for the Welfare of People with Epilepsy, KAWE, one of Africa's most prominent epilepsy organizations and the Kenya chapter of the International Bureau for Epilepsy. Patrick is a force for good and is actively promoting affordable solutions for people living with epilepsy in some of the most resource-constrained settings. We're so fortunate to have him join us today. So thank you both so much. And now I'll turn it over to Professor Ley Sander to share his slides.
Thank you very much, Gardiner. It's really it's an honor to be here. We all know the good work that PAME is doing, has done, and the message that it's sending out that we need to do something about the premature mortality that affects so many people with epilepsy. But that's not just, there's so many things around it. And I will try to share with you today a few. Can you see my slides?
We can see them. Yeah.
Okay. So I'm going to talk and I'm going to ramble on about stigma, care equity, and the role that this plays in the mortality, the premature mortality in epilepsy, which is the most tragic burden that epilepsy imposes on people. So epilepsy affects at least 50 million people, and I suspect it's more likely 75 million, because this data is a little bit outed, and there are some issues with the way it was done. And I think it's fair to say that the great majority of people with epilepsy are in poor resource settings. So poverty and epilepsy go together. High rates of comorbidity, that's a big problem, because epilepsy hardly ever comes alone, and it has many other issues, health issues that are often lost in the agenda. And I think it's important that we remember this. These comorbidities are an important part, as I said, because they affect the quality of life. They increase the stigma, they increase utilization of health service, where already there is very little. It increases the financial cost to the person, to the community. It has a definite role in premature mortality and complicates management. And it's important that we remember this. The mechanism of action for this, they might be very different why things go together. But one common thing in many of this is going to be poverty, and I will come back to this. So when we can have a chance association, you had epilepsy with something else common in population. There might be times that someone has a head injury, it might end with a paresis and epilepsy. So there are many different ways that these comorbidities can play a role. As I said, epilepsy has a social consequence, financial consequences, and it is a condition associated with poverty. And we think that often we think that it's the dragging down of effect. People have epilepsy and they pull down. But there's more and more data coming showing that already poorer people, they start at the lower the risk of epilepsy is higher. That doesn't mean to say that wealthy people, very rich people won't have epilepsy, but the majority of people, they will be in the poor side of society. And as I said, this will play a role in the terms of the lack of care equity. And that's one of my big issues that I have with the way that we see our health system. So if we are in a rich country, high income country, the incidence of epilepsy is about 50 new cases per 100,000. But that's more than double if you are in poor resource countries or high and low and middle income countries. So that's something that we need to remember, and we should be doing something about it. But it's not really just in low and middle income countries. Even if you are in London, if you're in the sort of poorer segments of the population, you still will be at a higher risk of epilepsy, as this graph shows. So the most deprived part of London, people living there are 2.3 times more likely to develop epilepsy. And this is something that we need to sort of try to understand. So why is more epilepsy in resource poor settings? And I think that the major determinant here is what we call the social determinants of health. These are the parasites, infections, trauma to the brain before or after birth, deprivation, social factors, and in some places where there's some societal ways of getting a merit, like arranged weddings, we might have genetic factors that also play a role. So this all goes back to the social determinants of health. This is all about the poverty. Is the care and access to good quality care, this community context, economic stability, education access, and the quality of education, and also the environment where people live. So that's the non-medical factors that influence someone's health. And as I said, poverty is a major determinant of health. And there's more and more disease coming out as part of this social determinants being brought up by this, from infectious disease, respiratory disease, cardiovascular disease, cancer, poor health behavior. That all goes with sort of people that do not have often ways to maintain or to keep economically. And this all leads to premature mortality. And epilepsy is not a benign condition. There is consistent findings that epilepsy increases the risk of an early demise. So premature mortality is a big issue. And if we looked at resource poor settings, every single study that has come from this area has shown that that there is a high, what we call standardized mortality ratio. This is how we measure mortality. And for instance, in Kenya, there is the SMR is over 20, and there are problems with this, that this might be an underestimate. So this is really important that we keep this sort of things in mind. And around all these health problems and poverty, we have the psychosocial risks of epilepsy, underachievement in education, if education at all, unemployment, underemployment. There's a lot of issues that will cause psychosocial problems. And the biggest of this is stigma. And stigma is how people see someone with a problem. It's the sort of social process where people tend to exclude, reject, blame, or devaluate someone because they are part of a group or because they have a health problem. And the case here, which we're talking about, is having epilepsy. And often stigma causes more suffering than the seizures themselves. And this is something that we need to sort of keep in mind why stigma is such a problem. And stigma, and it leads to exclusion from school, from jobs, from society. And reducing stigma is a key to improve quality of life of people with epilepsy. And we should be developing and thinking about effective policy initiative to actually decrease the disparity we have in epilepsy care, which is consistent and overwhelming evidence that the care for people with epilepsy is really deficient. And this is not just in the and sort of low income countries, but also in high income countries. The care standards that we should be looking for epilepsy is really make people seizure free, because this will change the way that people will live their life. They can actually go back to a normal life. And I think that we should always think that, the role that the poverty plays, stigma plays, and one perpetuating the other, and we should try to give to people equity of access to healthcare. And this is a very important thing. You could say that it not only applies to epilepsy, but it applies to many other conditions. So the takeaway message of my rumble here is that social determinants of health, they play an important role in epilepsy. The epilepsy also drags down people. And many risk factors and causes of epilepsy could be preventable, like CNS infections, brain infections, infestations with worms, for instance, um, meningitis, encephalitis. They all could be prevented with basic sanitation. And we should really be looking for this because these are some of the biggest drivers for epilepsy in low income countries. And health access is a fundamental human right. I think that is no doubt in my mind that everyone should have access to good quality health. And we should be always trying to see if we can prevent things. It's always cheaper and better for everyone, for the community, if we can prevent. And how do we anticipate problems? So I think that it's time for the International League, the epilepsy community, to make a effort to bring epilepsy out of the shadow. We should take a firm stand. So I'm really uh, aware of the organizations that are doing this, but they need help. And it's the case, for instance, of the wonderful work that CAVI does in Kenya. They need support, but also CAVI should have clones or whatever we call them in many other sites. So I will finish here. The message is clear. We need to decrease stigma. We need to improve social economic status, equity, better equity health. And then we will make a real input into input into this. Thank you very much for listening.
Thank you, Professor Sanders. That was an excellent overview. It's so sobering to hear about it, really, always. Next, I'm going to show the film, and which hopefully illustrates what you've just laid out. The sound, I practiced before this webinar, and the sound's not awesome, but I think it works fine. So let's give it a go here. And we'll take questions at the end, if that's okay, Dr. Sanders. Um,
The first time I collapsed here, I collapsed in the kitchen. It felt like my head was spinning. I didn't understand what it was. I think maybe I'm bewitched. Maybe I'm cursed.
The society has modeled this idea that the moment someone falls down and starts jerking, this person is cursed, is bewitched, has started to show demonic tendencies.
I lived in shame for so long. I couldn't share with anyone that I'm epileptic. What would they say? I used to avoid people. Stopped going to church. Stopped working. I just stayed here. I just said, like, epilepsy, like, at times it doesn't
Sorry, that was
give signs. You can collapse anywhere.
Photography is my thing. That's where I don't care what is happening around. I'm just in my zone. The reason why I like photography is that photography challenges perceptions and gives perspective. Whenever I'm into my role as a photographer, I feel like I have my fate in my hands. I get to decide what will happen with me. My mom tells me I was born with epilepsy. However, my first memory that I remember having an experience was 7 years old. It was early in the morning around 8 a.m. There used to be a basin with water. It was under a guava tree. My mom taught us when you wake up, the first thing you do, go there, wash your face. And when I started washing my face, my left eye started twitching. And I remember my mom came, and while twitching, she kind of hugged me, and the twitching just vanished like that. Epilepsy takes a piece of yourself. Every attack never leaves you the same. There's a piece of you that goes away.
Here in Kenya, we don't have school for epilepsy, which is a challenge. Dorcas have gone to a lot of school. She go to this school, they don't accommodate her. They chased her away. Dorcas would cry, and cry until I tell her, it's okay. We will find another school. If they chase us there, then we'll find another school. We will go around to every school around. Yeah. A lot of people lack knowledge. So I could tell them that epilepsy is controllable. And we should love children with epilepsy. We should show them love and love their children. And they should not fear anything. Because if you fear, you will not be able to deal with the situation. So you should be have confidence in you and deal with. When you look at me, I'm not scared, right? But inside, say, "Ay, what have happened to her now?" I just panic inside. It's hard to deal with epilepsy, but Dorcas is a very courageous girl.
So epilepsy is a neurological disorder that affects the brain. And currently we talk about 10 million to 15 million patients with epilepsy on the continent. It's quite a huge number.
The people living with epilepsy in Kenya are about 1 million. The population is about 52 million. With 18 per thousand. In the United States, it's 10 per thousand. So you can see almost twice.
There's also this high level of stigmatization that comes with epilepsy within our continent. I can cite an example of a country like Tanzania, where still in one of its statutes, it measures that a person can be divorced if they are having seizures or epilepsy. So most people, because of shame and fear, they continue to live in the shadows. And that's why the numbers that we can talk about are actually an underestimation. So it's quite a challenge that we have on the continent.
My childhood was awesome. Yes, I was a naughty one. My family has been my support system all through for 10 years. They have never given up on me. My son makes me strong because I have to fight every day because I want to see him longer. He doesn't know what epilepsy really is, but I've, enlightened him a bit. Mom is not in good health. She usually takes medicine in the morning and at night. He thinks that I'm capable of anything and everything. My husband, he became violent because of my health. He started coming home late and, sleeping on and off means I would get seizures. It's not like I was asking for it. Just to come out of triggers, the noise, lack of enough sleep, the fights. The first time he pulled my locks, I lost locks on this side. At some point, he was sexually violent. Whenever, he wanted his conjugal rights and was not in a position to, he would become physical or even force himself instead of understanding that I couldn't. When we were parting ways, the words he used were really painful. He's glad he has broken up with a mad woman. It's like mental torture. Because I was expecting him to support me, but instead he was torturing me.
Naitwa Nancy Waboya, mzee wangu anaitwa Naftali Kimani, niko na watoto watatu. Ninyona ni mundu wa mwanya na ti kawaida gukorwo ukiona mundu ta uyu uragukua wina thina tingi na ndungiona ingi na ndimwendete to tingi ungiona mundu urakuoya uguo ndimwendete muno.
My name is Naftali Kimani. I'm from Kiambu. This is where home is. Nancy Wafoya is my wife, and I love her very much. I don't think in this world I ever find such a wonderful woman. I didn't know that she had epilepsy. It is until that she was about 7 months pregnant. She was taken to Kenyatta Hospital, and she was in a coma for 2 weeks. And then she was diagnosed to having epilepsy. I had had it before, but I never thought it would come to somebody that I was related to. Every time that she conversed at night, I was like, is she the only one undergoing this? Why me? Why her? The society that we are in do not fully understand what epilepsy is all about. They all think it's a curse. People, they say it's a demonic attack, curses, or someone who has been bewitched. Most people go to churches where they seek miracles. We had done so. That did not work. So I had to seek other ways of getting her healed.
Twathiĩ kũu rĩ, ithuĩ nĩ twokire na tũgĩka na tũkĩgũra ngui tũkĩruga na tũkĩrĩa, no andũ a community ti othe mekaga, nĩ amwe na amwe. Twarĩa ngui rĩ ndiahonire, ona nĩ gũthũka mathũkire biũ. Rĩu ona tũkĩũria atĩrĩrĩ, rĩu ona twagĩthĩnja yake na ndĩrarehe kĩhonia. No ndingĩrĩa mũno, kana nĩ arĩ imwe ndingĩririkana kuona ndiawoire na ũritũ, tondũ niĩ kũrua ndingĩrua.
The world is full of evil people. The world does not care. Neither the authority does not care about people with epilepsy.
We need to embrace people with epilepsy because they are people just like the rest. Epilepsy is not about witchcraft. It's not about curses. It's a sickness just like any other. I usually take my medicine because if I take them religiously, I take so long without getting seizures.
We have demonstrated that epilepsy is treatable. We can manage epilepsy at the lowest cost because we use what we call generic drugs. The key thing is stigma. Once you reduce stigma, people access healthcare, they'll be treated, they'll regain control of their lives, and they'll lead meaningful lives.
Medications are affordable and life-saving. And according to WHO, $5 can actually help a person for the whole year.
She used to hurt her head, her hand, everywhere she had injuries. But now I saw some changes, which I said, hey, Dorcas, you are becoming better and better every day. Now she stayed long hours without falling, which she is happy because she is able to be controlled by the medicines. I believe that her future is bright, and one day she's gonna make it. She would like to be an architect, engineer. Whatever her dreams, let it come true.
Ngiuga atĩrĩrĩ, mũndũ wa mbere nĩ kwamba kwĩĩtĩkĩra na gũthiĩ thibitarĩ na kũnyua ndawa, gũbuatĩrĩra mawaitha ma ndagĩtarĩ ũrĩa akwĩra na ũnyue ndawa. To nginya ũtinde ũgĩbuatĩrĩra mathĩna macio mothe.
We need to tell our story with our voices. We need to let people know what you are going through. And that's why I'm saying it is important to come and share your story, because if you don't, someone else will be sharing your story in their own understanding.
Yeah, like the normal people around. Because we breathe the same way, we walk the same way.
The more you talk about it, the more you realize it's not that bad. The lie that epilepsy tells you that no one is going to accept you. So tell your story. You're not responsible for how someone is going to perceive. That is their issue. Don't make it yours. So when you share this story, when you put yourself out there, someone else is going to be inspired by what you do. And maybe you might not get to enjoy the fruits of the tree that you're planting right now. But who knows? From the extension of your family tree, someone is going to experience that freedom that you so have.
Okay. Hope everyone's still there. Hi, gosh, I've seen the film so many times, and every time I see it, I fall in love with the people in the film that much more. I'm just so blown away by their willingness to share their stories. And I am just so thrilled, Patrick, that you're here with us. And you know, you're the star in the film, and Kawe is doing such important work. Oh, someone pulled that up for me. Patrick, you're sharing your screen. Great. I was going to pull your slides up, but you've got it. Okay, I'm going to turn it over to you to tell us about the great work you guys are doing in Kenya and how stigma is actually being tackled. So thank you.
Thank you so much. First, I'm very grateful to be in this platform discussing this very important matter of stigma. I will discuss some few interventions that we've done in Kenya, in a county called Kisii, is one of the rural counties, where the young man is trying to point. Basically, some of the slides are a bit long, so I'll be very quick. Some of the key objectives of this campaign was number one, to raise public awareness on epilepsy, stigma, risks, and myths, and to empower individuals with epilepsy to share their stories. You know, I am a firm believer of lived experiences. I believe there's nothing that beats lived experiences when it comes to stigma. Number three was to encourage policy discussions at local and subnational levels, and also to promote social inclusion and the rights of people with epilepsy within the community. Some of the activities that we did were quite a number, and we're still doing them. So one was to do community dialogue sessions. We call them the stigma benches. We held them in the public spaces, the churches, the markets, the schools, and the community centers. And we also had we encourage people to also discuss, you know, the caregivers, the people with epilepsy, to tell their stories, the personal testimonies. We also did special awareness sessions in prison, in the main prison in Kisii County. And we also did some contact-based interventions. We did a workshop where we did community health promoters, sensitizations about epilepsy, and then also to equip them with the skills, epilepsy advocacy skills, using the toolkits that the IBE and the Band Foundation has been able to structure for us in Africa. We also did a lot of media and digital outreach, use of radio, local radio stations, TV, social media, podcasts to try and reach a broad audience. We also did establish an epilepsy convener in the county with government and all the key stakeholders, with other neurological disorders, so that we can approach this matter in a holistic way without leaving anyone behind. We also shared a lot of awareness materials, basically, IEC information, education and communication materials. We distributed a lot of posters, brochures, and handouts in the streets, in the markets. And interestingly, we also did a survey, and we'll discuss later about the survey. Some key achievements that we achieved here were quite interesting. The awareness and stigma reduction was we did a lot to reach quite a number of people with limited resources. So we used the government system, the local system, to try and reach as many people as possible, and also held epilepsy sessions in KMTCs and the CHPs and the chiefs barazas. You can see here there's a convener and the media. And then also we did some key achievements. We signed an MOU with the county so that we can enrich the county to do more, and train champions so that they can further answer the work that we've done, so that we just don't go there. It's a rural county with about 1,200,000 people, so we just do a lot of things and then we just leave. No, we needed to create some sustainable solutions so that it can be an ongoing work. So, and due to this work and the outreach that we did, one of the local philanthropist has promised to construct a clinic in the county, and we attribute that to the work that we've done, and to the documentary, because we had a showing there as well, and it was very effective. So some of these pictures you'll see there, those are some of the stigma benches that we did in 6 of the 9 sub-counties of this county. And then the documentary, you can see some of the faces that you've just seen from the film. We also received a lot of good support from the government system, to the extent that the film was classified for free. And because before you show it, we need to go through some classification, the age set and all that. So the government saw the kind of work we've done, and they've been trying to help us and support us, and we attribute this to consistency and good campaign about stigma, and we thank God. We have also issued some epilepsy champions. So everyone who talks about epilepsy, especially people with epilepsy, we give them this stretcher and recognize them, and they become our focal point, because we want this initiative being driven by people themselves, so that we can achieve what we need to achieve, and something long-term, something sustainable, and we can entice a community dialogue that was not there before. And this county in particular is very interesting because it has a lot of cultural issues, and we have data that does not really speak to us, because out of the data that we had, we were being told we have about 4,000 to 6,000 cases by the Ministry of Health. But when we went to the ground, we realized that this data is not really accurate, and that's why we decided we start this pilot campaign in this county, and we've seen some great strides. So the CAP survey, this baseline that we did, it's a knowledge, attitude, perception survey, and we wanted to understand the community, to engage the community to understand exactly what drives this stigma. Why are people with epilepsy not integrated within the society, in the community? Because you will notice that we are talking about 1 million cases in Kenya, but we have realized that epilepsy is a social disease, is a social condition. So if one family member has epilepsy, and the family has about 7 members, so you're looking at almost 7 people who have been affected within that family. If you're looking at about 1 million cases, you're talking about 7 million people directly being affected by this condition. And that lies in the reason as to why we should take initiatives and combat this stigma. So we did a dissemination of this survey that was done to 450 participants in 293 villages. And we engaged the Department of Health. You can see here we're disseminating that with the minister within that county. And it was a call for us to understand that, yes, we have been talking about epilepsy for quite some time now, but it's high time that we hit the nail on the head. We demonstrated our willingness to combat this monster that we call stigma, because that is what brings about the treatment gap. It's what hinders people accessing healthcare and distort the outcomes, the health outcomes. So before we can even engage on the aspects of the treatment, we need to first get people out of the shadows, like Prof has just said. And it is important that we do with the care, with the consistency, and with the same enthusiasm that we've been having all along. And we do not need to reinvent the wheel. We just need to engage people with epilepsy themselves, like in this film, to talk about the condition, to say this is not witchcraft, to say this is a condition like any other, and that people can get interventions at the other facility. And the findings were quite interesting. Part of the county was quite. There was a county where people think has affluent people, and so people would think that is a place where people have more information. But we realize those are the people who do not even have any information about epilepsy, and it was quite disheartening. But the survey is out there, and I am hoping that at least. And can share these slides and see. So some of these issues we may not have time to discuss all of them, but they will tell you that the barriers to social inclusion by these counties lies in with the beliefs of the community, lies in with the fear of the healthcare workers to treating epilepsy, and then and that now meant we have to go back to the drawing board. We have to engage the Kenya medical training colleges so that we can engage the primary healthcare workers to be able to have that confidence to treat epilepsy, so that we can be able to bring confidence within the community that yes, once we go to the healthcare, we will get the outcomes. Initially, they were finding it easy to go to the witch doctors, the witchcraft, and they would get interventions there, and at the end of the day, the health would deteriorate. So these are the regional disparities. These are different sub-counties of this county. The highest belief in witchcraft was in Nyaribari, Masaba. And then the highest comfort in interacting with people with epilepsy was almost about 91% based on the data that we received. This Bobasi sub-county had the highest perceived barriers to inclusion. And lessons we've learned from that campaign, it's a 12-month campaign, with that if we had funding, we would have had a broader reach. Maybe we would have reached 9 out of 9 sub-counties with the stigma benches instead of 6. And then also the political unrests. We had some issues in the country. And then also the county turnover. And then we have also realized that we should have signed these MOUs a little earlier, because once you sign MOUs with government departments, the setting is always very different, and they take these whole initiatives very seriously. That's all. Thank you so much. I hope that there'll be some questions that we can discuss a little more. Thank you.
Thank you, Patrick. That was excellent. Just seeing how I can get us all here on the screen. Do you want to stop your share for a sec? There we go. Hi. Patrick, why don't you come join us if you can? Thank you both so much. And you were excellent on staying on time. So thank you. I've got a few questions, and then hopefully if anyone out there in the audience has questions, you can send them in the chat. But Professor Sanders, I wanted to ask you about two questions. One is, can you explain a little bit more about the SMR, the standardized mortality ratio, and why it's so much higher? You touched on some of the elements, I think, but if you could kind of explain that a little bit more, because for people who aren't like people, like SMRs are kind of, I think, hard to get your head around, and it's a pretty staggering number to me.
Yeah. Indeed, you're quite right. They are staggering. Actually, one of the paradoxes we have in epilepsy is the discrepancy between the incidence and the prevalence. If our incident figures are correct, and they're likely to be, not completely incorrect, we should expect more people with epilepsy in the prevalence pool. But the numbers are usually a third of what we should expect. And there's been a lot of discussion, and this is called the epidemiological paradox of epilepsy. Why this discrepancy? And some people like to think that this is the drugs curing people. Some people could go and, have a self-limited condition and get better. But I think that the great majority of people actually do not make it. And that's why we have this discrepancy. Now, let me try to explain standardized mortality ratio. That's SMRs. That's the most important, or the public health measurement of what we call premature mortality. And this compares the number of deaths in a group under surveillance or under study or under, of interest. For instance, in our case, is epilepsy. So we will have usually, even in very poor societies, there are available what is called life tables. This is the number of deaths that have been registered every year and, compiled from death certification. And that will provide what we call the sort of community death rate. So we looked and saying, in this community, people die with this age, and this age if they're males or the females. So we have what is seen as the natural or as the control mortality. So when we looked then at the death within our group, and we tried to establish a ratio. So just to tell you, an SMR of 1 is the same of the population, the general population. If you have an SMR that is 0.5, that means that the population that you're studying or you're following is protected from dying earlier. Now, if you have an SMR that is 2, that means that people are twice as much to die earlier than their peers in the community. Now, you need to also remember that younger people die less than more elderly people. But in some communities, in some resource-poor settings, people do not make it to a sort of senior age. So you have a sort of slightly different demographic, pillars or pyramid. Mm-hmm. But it's really something that the epilepsy community does not take into account as much as they should. I think it's a staggering, it's scandalous SMRs, and it's been consistent finding. And I tell you a story. I got involved with this many, many years ago. I did my PhD looking at outcomes, and that's how I got to know Kenya. I was in Kenya in the 1980s in Nakuru, and we were looking at epilepsy there. And one of the things that actually at that time was very clear, and you keep hearing stories of people dying. And I also did a study in the sort of rural areas of Ecuador and South America, and we're seeing the same things. So when some years later, I went to work with the WHO, and we established some demonstration projects. And one of the things we did in some countries was to actually look at mortality. And we done this in Brazil, and we done this in China. But in China was actually staggering. We found SMRs of over 80. And this is people dying 80 times more likely than their peers. And then when we went to look at this area, what happened was that people with epilepsy in China, if you're in rural China, the natural history of the people is to immigrate to places where they can work.
Mhm.
Now, if you cannot immigrate because you have epilepsy, you're gonna be a burden in the places. So people don't leave the rural areas. But in this part of West China, the only thing people can do locally is to tend the paddy fields. So if people then working in the paddy fields and they have a seizure and they drown. So we found that half of the deaths in this region, and it was a staggering high. I actually, when I saw it, I didn't believe it. I thought there was something wrong. And we repeated this exercise then in 5 African countries, and we found again very similar numbers, high numbers. The younger, the highest the SMR. But of course, you need to adjust SMR because younger people die less. Yeah,
Right.
but if you're still getting 10 times more, that is really significant. This is really staggering. But this will take me back to China, because in China, when we found this, our Chinese colleagues, they were sort of reluctant to publish this because they say the local leaders, the community, the ministry won't like this. But actually, the contrary happened. When the leaders of the health system, of the Minister of Health, found out that many of these deaths could be preventable, they really turned epilepsy around. And nowadays, China is a model for doing good work, creating clinics, creating a national epilepsy program that has been now spread to almost every province in China. And it was showing from the public health perspective this increased mortality that led them to change. But often people say, well, it's not good for us to do this because it can actually frighten people. It can do other things. But I think that is the ostrich approach. We have a problem. We need to face it, and we need to get it sorted. And I always in my slides, when I saying, the goals when we look after epilepsy is to decrease this staggering high premature mortality. And SUDEP is actually not the biggest culprit. SUDEP is actually, if you look at an incident population, SUDEP is a small part of the problem. SUDEP is more a problem in the sort of prevalent pool. But in the incident pool, and even in the prevalent, the biggest problem are the comorbidities. So they don't figure because someone has a heart problem and dies, or if they have some sudden death, they will be put down as a heart problem. So this does not figure in as an epilepsy death. And we see this even in the UK. We done this exercise twice, and we found out that even when people were known to have severe epilepsy and that the epilepsy must have contributed to their death, epilepsy was nowhere in the death certificates. So many of the data that we see is actually the tip of the iceberg, because most cases that rely on death certification, you won't actually identify them. So the epidemic of death and epilepsy is not seen as a problem. And that's one of my issues.
Well, you're doing a great job raising awareness, and we should continue to brainstorm on how we do it. That was an excellent answer. I've got a question for Patrick, but Patrick, before I get there, there's a question in the chat, Professor Sanders, about just exactly what you're talking about data collection being like such a huge challenge in Africa, particularly, and that there are issues around collecting this data, right? So do you have any specific tools or resources that you could share to help people overcome it? Like, perfection can't be the enemy of the good, right? At the end of the day, It's important to just have information, right? Just to describe things, even if it's not perfect.
Yeah, that is a real challenge. It's how to identify people that have epilepsy, because one of the issues with the treatment gap is a lack of awareness that this is, for some communities, that this is a disease of the body that can be treated. So a problem of the diagnostic gap You have that. People are not diagnosed, but often they do not come forward because they do not see that as a problem. Now, in places where you have not a very sophisticated health ecosystem, you cannot rely on, clinic lists of people attending or pharmacy lists. So the way to actually, that has been done in Africa, you need to do screening. So you need to actually go to the community and you need to understand what epilepsy is in that community, how it's seen, what are the health-seeking behavior of that community, but also how epilepsy is seen. So, for instance, we done a big work in Nigeria, and we went to 3 different areas of Nigeria. Nigeria has over 200 ethnic groups, but most of them come under 3 big sort of meta groups: the Yorubas, the Igbos, and the Hausas. So if we went to each one of these, it was different beliefs about epilepsy. Even the words that were used were different. So, you need to really make sure that you're screening that is socially and culturally adaptable to that population. And that is the challenge.
Got it. Do you have, we have 2 minutes left, so I want to give Patrick a chance, but Ley, do you have any resources that you can direct people to?
We can, yes, I can send you a few screening
write
questionnaires.
anything in the chat or send them to me. Like I think that's the important thing to get out there, and that's an interesting example of Nigeria. So quickly, we have 2 minutes left. Patrick, I have a question that actually mirrors a question in the chat. You talk about a lot of awesome interventions you are doing in the ground. KC is a great model for how progress can be made. There's one intervention that you kind of touched on that I think is really interesting, because we don't have the same thing here, but it seems I hear about it a lot in Africa, and it's about the stigma benches. I wonder if you can talk about that a little bit. And I think the question in the chat was about it was something anyway, you talk about that, or how effective that is, or if there's another one approach that you want to scream out in a minute. Sorry.
But stigma benches, I think it's one of the single biggest we can say one thing we have discovered that is a very effective tool towards having people with epilepsy come out and talk their issues in front of people who can actually intervene, because we bring these benches in front of the chiefs, in front of the people who can, administrators who can actually help these people. And once they air their issues, and including social interventions that the government is coming up with, tax benefits that the government is coming up, it's very important that they talk those issues when these government officials are there. So that they can get real-time answers and also be able to go and tell their friends that there is an intervention somewhere. With regard to this I have seen a question that someone is asking about the fear of the physician diagnosing epilepsy. Yes, it is a big problem, because I think our schooling system has had it. We have very limited time allocated for epilepsy for our primary healthcare workers, to the extent that when they go out there, they have not interacted with this condition, they have not interacted with these issues, and they always refer up. And that is why we need to go down there and give them this capacity, so that they can be confident again and see the people without necessarily referring them.
Thank you guys both. This has been tremendous. I'm excited about all the activity in the chat. I'm sorry we can't answer all of this, but we'll try to follow up on some of this offline. But thank you both for the work you do in this space. It's tremendously important, and we need to continue these conversations and figuring out how we get these messages out there, and we mobilize more support. I mean, just Patrick, to hear that by showing that film and doing those activities in Kisi, you got a donor interested in creating a whole nother clinic. I mean, wow, like that made my day and some. So congrats to the work you're doing, Ley. Thank you for leading the charge on this, and thanks for being friends of PAME, and thanks to all of you for tuning in, and to UCB for supporting us. Okay, have a great day.
Take care. Yeah, bye-bye.
Bye.
Thank you.